I'd like to welcome you to tonight's Wu University's webinar. I'm your host, Dr. Jennifer Stewart. It is my great honor to introduce our speaker tonight. Dr. Jacob Lang is a key opinion leader and influencer dedicated to educating colleagues as an early adopter of novel therapies to enhance patient care. He's a fellow of the American Academy of Optometry, serving as chair of the anterior segment section while holding adjunct clinical faculty positions at the Illinois College of Optometry, the Ohio State University, and Salus University. He's active at all levels of optometry, participating in the Intrepid Eye Society as vice president, the American Optometric Association, and the Minnesota Optometric Association. As chief editor of Presbyopia Physician, and as a member of editorial boards across numerous ophthalmic publications, he educates, mentors, and elevates the profession. Through his engagement with industry and being an investigator for dozens of clinical trials, he is at the forefront of innovation and research as a leading peer educator. As a result, he's lectured on eye care extensively, presenting over 200 hours of continuing education. I guess this is 201 now. Dr. Lang is the medical director of dry eye services and residency director at Associated Eye Care, practicing full scope optometry with expertise in dry eye disease, comprehensive optometry, therapeutic contact lenses, and surgical co-management. So with that, welcome, Dr. Lang. We're excited to hear from you.
Thank you. Thanks for having me. Yeah, that's a lot. I appreciate you reading through all that. You didn't have to, but thank you. And we'll just go through all 200 hours that I've presented, so you guys are all up to date on all the things eye related. I will have a couple little polls in here. I thought we'd try it being a virtual team, virtual group here. Might give you some ability to participate a little bit. It's always nice to see what others think out there too. So we'll have a couple little polls. There should be a QR code that pops up with the poll everywhere too, so you can scan that with your phone and vote, or you can go to pollev.com or text Jacob Lang 676 to 22333. Again, Jake Lang. We're going to talk about thyroid eye disease, or TED in eye circles. I'm going to refer to this as TED. So if you hear me say TED tonight, it's not what you think about on NPR, which extra credit for anyone that can chime into the chat with what regards what TED stands for in regards to the NPR show. This is thyroid eye disease. And so in eye circles, when you hear TED, you should think thyroid eye disease. And things are evolving a lot in this area, and it's important that we are all up to date on what's great, what's new, and how we can best deliver care to our patients. So we're going to focus on that tonight. Again, here are my disclosures. And so we'll jump right in to talking about some thyroid conditions. Specifically, we'll talk about Graves' disease. So Graves' disease affects approximately 25 per 100,000 people. And its root of Graves' disease are these autoantibodies that stimulate the thyroid stimulating hormone receptors in our thyroid, which causes excessive production of thyroid hormones. So it turns your thyroid on overdrive, typically. And so this hyperthyroidism typically is treated by inhibiting the production of those thyroid hormones. And you can do that in several different ways. Most commonly is radioactive iodine therapy. So we're using radioactive iodine to essentially kill the thyroid and therefore turn down the production of those thyroid hormones. We can use medications to do similar things. We can use surgery to remove the thyroid. All of these things usually require, if we eradicate the thyroid completely, our patients therefore need thyroid supplementation. So Synthroid will be part of their daily diet for the rest of their lives. So I'm sure you've all seen patients on Synthroid recently in their meds list. Again, some of the other things we see listed here, the goiter that we can see with this hyperstimulation of that thyroid, obviously the orbitopathy findings that we're going to delve into deeper. There's some dermatitis things. So this is on a tibia. You can see some dermatologic changes in patients with autoimmune thyroid disease, as well as some skeletal things with the clubbing of the fingers that we see here too. So a systemic autoimmune condition, but seems to have roots in the thyroid. And then we'll talk about thyroid eye disease. So thyroid-related eye disease, about 16 out of 100,000 women, 5 times less likely in men. So very rare or more rare in men. But when men get thyroid eye disease, they tend to get it in spades. By that, I mean they have more severe disease. So if you see a man with thyroid eye disease, you have to be extra careful, extra worried, extra aggressive. There are these 2 big peaks of incidence that occur in patients between 40 and 50 and 60 and 70 tend to be these 2 peak incidents of thyroid eye disease. So if there's something good about the 50s, it's that your presbyopia is plateauing and that you're less likely to get thyroid eye disease. Smoking is a huge risk factor for thyroid eye disease. So 8-fold increase in thyroid eye disease in smokers than non-smokers. So just such a huge risk factor that we have to take a little extra time, educate our smokers that might have thyroid issues, that this is a big association with thyroid eye disease. And those patients with thyroid eye disease really, really have to stop smoking. I know we still don't see smoking as much as we did maybe 20 years ago in the United States, but it's still a common thing in many areas. And it's our job as primary care providers to educate our patients about what these decisions, these social decisions might have on the health of their eyes. So huge, huge, huge risk. 20% risk of new or worsening thyroid eye disease after radioactive iodine therapy. So if they have radioactive iodine therapy to treat their hyperthyroidism, it actually puts them at more risk for thyroid eye disease. So if you know a patient that's going through this, that's going to be going through this, you might want to follow up with them a little bit more closely in that perioperative, peri-procedural period so you can screen them more closely because they're at higher risk for worsening of their thyroid eye disease. Even if they already have it, it might get worse, it might flare up. Or if they haven't had any thyroid eye disease, they might get it for the first time in that peri-procedural time area. All right. Again, epidemiology of thyroid eye disease, 16 per person, 3 per 100,000. Those 2 peaks of incidence, again, female versus male, much more common in females than males. All right, here's our first poll question. I'll give it a little bit just to see if people are on there. I don't want to dwell on this too much because we have a lot to talk about, but please feel free to vote. I'm always checking them afterwards too, just to see what people thought. All right, it's working. God bless the internet. Does treating hormonal abnormalities help treat thyroid eye disease? So when you see a patient with thyroid eye disease, a patient that has thyroid eye disease, if they see their endocrinologist and they get their thyroid levels, their TSH, T3, T4 back into better levels, if they're more euthyroid, is that going to help their eyes? That's the question. I did this early as a provocative question. That's great. Everyone's chiming in. Please keep chiming in. I love to see this. This is great. Awesome. I'll keep moving forward here. So does treating hormonal abnormalities help treat thyroid eye disease? Actually, no. And that's one of the big things we're going to kind of talk about here, no being the answer there. That thyroid eye disease, I want you all to think of thyroid eye disease as its own separate disease state. It's not completely, but if we think of it like that, I think we'll have a better perspective on this condition and this disease. For too long, I think we've been maybe miseducated that it's just part of Graves' disease. And really, as we're learning more and more about it, it's kind of a separate thing. So thyroid eye disease, it's the most common orbital disease in North America. It's often associated with Graves' disease, but not always. And we should think about it as a separate condition. Hyperthyroidism being the most common, or Graves' disease being the most common form of hyperthyroidism, but it's a distinct disease. Underlying systemic thyroid function does not resolve the ocular signs and symptoms. And this is not technology, entertainment, and design, as you might have been listening to on NPR. All right, so what is thyroid eye disease, and what is the root of thyroid eye disease? So at this condition's pathophysiology base is the activation of orbital fibroblasts by antibodies. So again, it's this autoimmune condition where we have these autoantibodies floating around in our body for, we don't understand why, but they lead to orbital inflammation, which we talk about so much in eye care these days, but orbital inflammation, not necessarily corneal inflammation, but anterior chamber inflammation, but orbital inflammation, hyperproliferation of fibroblasts and adipocytes, so fat and scar tissue, extracellular matrix being just ramped up in the orbit. And that's spurred on by those autoantibodies. We'll talk a little bit about that, more about that later. So again, activation of those fibroblasts and autoantibodies, which lead to this characteristic orbital inflammation and inflammation of the extraocular muscles, the fatty tissue in our orbit, which leads to that common appearance of thyroid eye disease that we all are familiar with. So again, what are we seeing in the eye as far as ocular pathologies associated with thyroid eye disease? Well, we're getting exposure, right? I got that proptotic proptosis and that proptotic appearance of our patients, which is going to lead to more exposure, more dryness, increased blink dynamics and frictional forces. So we're going to get a lot more friction between the eyelids and the globe and the cornea, which leads to more ocular surface issues as well. It's an inflammatory condition, so we're going to see signs of ocular inflammation and those symptoms that are associated with ocular inflammation. So all the things we see in inflammatory, other inflammatory conditions, light sensitivity, pain, redness, burning, watering, all those ocular inflammation symptoms. And then again, associated with that autoimmune condition. The big things we worry about, the sight-threatening things that we worry about, compression. So that orbit is only so big, and if we run out of room back there behind the globe, we'll actually get compression of the optic nerve, and just like an aneurysm or a pituitary tumor, we can get damage to that optic nerve, which can be sight-threatening. It can cause complete vision loss to our patients. So that's one of the huge things we have to worry about, obviously, is sight-threatening optic nerve compression. And then diplopia, very debilitating. We're getting EOM inflammation, infiltration, and fibrosis. So we'll get inflammation. You can see on that CT scan above, those EOMs are really swollen, and obviously a muscle that's swollen isn't going to work the way it's supposed to, which leads to this kind of irregular, non-comitant strabismus in our patients, this restrictive diplopia that we'll see in patients with thyroid eye disease. The other big sight-threatening thing I wanted to mention here is if you have so much exposure, you can get corneal ulceration because of that exposure, that dehydration of the cornea, and eventually actually perforation of the cornea as well. So the two big sight-threatening things here, corneal breakdown, corneal perforation, optic nerve compression, so the front and the back of the eye. But most common manifestations of thyroid eye disease: chemosis, conjunctival redness, epiphora or epiphora, depending on where you are. Photophobia. What does that sound like to all of you? What is that you see all day, every day? That sounds like a lot of my dry eye clinic, right? So redness, watering, inflammation. So lots of overlap with ocular surface disease. Eyelid retraction. One of the big hallmarks of thyroid eye disease, eyelid retraction. I want to drive this home. 91% of patients with thyroid eye disease will have some eyelid retraction, but we'll also see eyelid swelling. So you might see that more as like a ptosis, that those eyelids are swollen. Pain, lag ophthalmos, incomplete closure, right? So some things to think about there with the eyelids. Proptosis, so we'll see the globe protruding or coming forward, getting that thyroid eye disease stare. 62% of patients will present with proptosis. Pain, they'll present with deep aches. They'll say it hurts kind of in my eye, not so much the shooting pain, but the deep ache. And of course, disfigurement. Patients will come in and my eyes look different. Something's different about me. And we'll talk about that a little bit more here tonight as well. And diplopia, about 51% of people will present with diplopia, double vision. It can be in more different gazes and not consistent, like we were talking about, non-concomitant. So if you saw a patient with thyroid eye disease, aha, I found you thyroid eye disease, now what? What would you do? Endocrinology, oculoplastics, neuro-ophthalmology. I know not everyone has access to these. As I've been talking to our colleagues, our optometric colleagues around the nation about thyroid eye disease, it's very interesting to me to see the diversity of access to things like subspecialists like neuro-ophthalmology or oculoplastics ophthalmologists and things like that. So we'll talk about that a little bit more, but everyone's a little different in this. You have to apply some of the things I'm saying tonight to how you would do it in your area with your village, right? You have this village of healthcare providers. That's your team. How are you going to work with your team to provide care for these thyroid eye disease patients? A good diversity. I don't think any of these are wrong. I think, like I was hinting to, it does take a village to take care of these patients, and I think the more providers that are helping these patients, the better. All right, risk factors again for thyroid eye disease: smoking, radioactive iodine therapy. Women are higher risk, but men get more severe disease. Age, so increases with age. Again, there's those two peaks, but there seems to be some propensity with the older you are, the more likely these things can happen. All right, so I'm going to run through a few cases here. I'm not going to spend a lot of time with these because I have another case I added of a patient I saw this week. So I added that in, but I wanted to just go through some cases because this is what a lot of you do all day, every day. This is what I do most days. And so here's a 52-year-old female with a history of Graves' disease, was treated with radioactive iodine a year ago, and then felt like she was getting this kind of bug-eyed appearance, really coming in saying, I don't look like myself. No double vision, no pain, eyes are dry. Synthroid, of course, best corrected vision, everything looks pretty good here. The injection across the horizontal recti muscle. So we're seeing that 3 and 9 injection, not because of exposure. Well, maybe because of exposure, but maybe because it's the muscles underlying that 3 and 9 position that we're seeing inflammation. So I just want you to think about that. When you're thinking about where you're seeing inflammation, why is that inflammation there? Is it because the muscle's inflamed, or is it because the conjunctiva is inflamed? Hertel's 24 and 25, and we can see that inferior and superior scleral show on normal optic nerve. So here's a CT and then post-surgical lid correction for this patient. You can see the inflammation in those extraocular muscles, fibrosis, scarring going on. You can just see how the belly of that muscle is just so swollen. And that's the hallmark when you're looking at CTs, is you're going to see inflammation, fibrosis in the belly of the muscle, not in the tendons at the tips, but right in the middle of the muscle is where you're going to see that edema. So when you're going to your next career as radiologist, you'll be looking for that in thyroid eye disease. So this is post-surgical lid correction. So this patient was corrected eventually and had a much more normal appearance for her. Here's another case. Again, proptosis here. We're seeing a little bit more proptosis, diplopia, and then their CAS scores. And we're going to talk a little bit more about that. But you can see the redness, the inflammation going on in the globe, the inferior scleral show, maybe some vertical deviation, and the lid retraction. So what is normal for exophthalmetry? I know you guys are doing Hertels on every patient, right? No, maybe not. Do you know where it is in your office, if you have one? How thick is the layer of dust on that Hertel exophthalmometer? So let's talk about what's normal. So if you're checking Hertel, what's normal, what's not? I always kind of think of Hertel as IOP. And so if your pressure is high, if your pressure is 30, you know that's not normal. If your pressure is 22, 24, it might be normal, might not be normal. So Caucasians tend to have exophthalmetry measurements less than 18 to 20. So 18 to 20 for Caucasians, a little higher than Asians. Asians are usually 16 to 18 millimeters. And African Americans or blacks tend to be 20 to 22 millimeters for normal for exophthalmetry. And then one more point, referring this as IOP, asymmetry. So if you saw a patient with pressure of 10 in one eye and 20 in the other, that's not normal. That should raise some red flags. Same thing with exophthalmetry here. So if you're seeing a patient with 18 in one eye and 22 in the other, that's different. It might be skeletal abnormalities are normal for them, but it could be a sign of disease. So any sign of asymmetry should raise some red flags as well when we talk about exophthalmetry. Again, there's that. There's another case, a little more obvious inflammation in the eyes, superior scleral show, proptosis. Again, a patient with pretty active inflammation with regards to thyroid eye disease. Proptosis here again, no diplopia, but their CAS score is 5. What is CAS score? Dr. Lang's talking about CAS score. What does that mean? So there's a couple other things that we'll see our thyroid eye disease specialists talking about besides just how proptotic their eyes are. Clinical activity score, CAS score, is I kind of compare it to the OSDI or the SPEED score for thyroid eye disease patients, and you'll see it listed here on the right. And you can see that pain feeling behind the globe, pain on attempted gaze, redness of the eyelids, chemosis. So it's a measure of trying to feel out how much clinical activity is going on, how much inflammation is going on in those patients. And then there's also a no specs classification that talks about like optic nerve compression, proptosis, how severe is their thyroid eye disease as a whole. So those two things you might see or might hear people talking about in thyroid eye disease circles. Here's another case. I think we can see that upper scleral show again here. Again, some proptosis, a lot more proptosis than I think I would have thought just looking at this patient. Diplopia 1, CAS score is 6. And that's one thing to think about too, is sometimes if you're not seeing that proptosis, but seeing a lot of inflammation and a lot of thyroid eye disease, be a little more worried, because if that eye can't come forward because of whatever reason, their orbital anatomy and things like that, it's more likely to compress that optic nerve. So if the eye can come forward and take some strain off of the nerve, that's actually less worrisome for the optic nerve compression. So here's a more asymmetric presentation like we were talking about. Again, pretty severe proptosis on one side versus the other. Just a reminder that this is a bilateral condition, but like glaucoma typically presents asymmetrically. You can see that inflammation in that EOM, the orbital fat next to it as well. That will show up more as well. This is kind of an interesting case, so I wanted to spend a little bit of time on this. So here's a 65-year-old female with 4 months of eyelid swelling that presents to your office, right? Seen several doctors complaining of the lid swelling. And if you looked at this patient, would you first say, oh, that patient has thyroid eye disease? Well, maybe this patient, right? You'd say, oh, yeah, that's thyroid eye disease. That's thyroid eye disease. Would you say that for this patient? Would you say this is something else? Would you say maybe this is allergic conjunctivitis or atopic dermatitis? What would you think? If it was allergic conjunctivitis, this would make quite a turn for the lecture. We're going to go back down those roads. So this patient was diagnosed as allergic conjunctivitis and inflammation, was treated with oral steroids for 8 weeks. So that patient was treated with oral steroids for 8 weeks and didn't get any better. So she actually got worse. She developed double vision. And at that point, the red flags went up and she said, aha, you have thyroid eye disease. Then was treated with IV methylprednisone for 6 weeks and then oral at 250. And then after that treatment with more steroids, I developed color vision loss. So where are we going now, right? Color vision loss hints to more problems in the back of the eye, compression of the optic nerve. So here's that patient after their IV methylprednisolone, vision's 20/80 in the right, 20/60 in the left. Intraocular pressure is elevated. Some might say, is that a steroid response? Or is it a congestion or actually, compression increase of the IOP because the globe is getting compressed? I'll let you decide. With orals, steroids, I think you could argue either way. EOMs in upgaze are restricted. APD in the right eye, color vision decreased in the right eye versus the left eye. You can see on that lower picture how much proptotic those eyes are, how much vision changes we have here. So definitely some inflamed eyes, some angry eyes. Doesn't look like allergic conjunctivitis anymore, does it? So I think, if we could detect that early and know what we're up against, no oculoplastics person wants to be doing emergent surgery to help save optic nerves if they can get ahead of it earlier. And that's where this patient ended up leading. When you see a patient with optic nerve compression from thyroid eye disease, they're going to get an urgent or emergent, really, orbital decompression. So they are going to knock out the bones of the orbit to make room for that optic nerve. Kind of a crude surgery if we think about the elegance of some of our cataract surgeries and corneal surgeries, just knocking out bones to make more space for inflamed tissue. So no one wants to be doing surgery on that sort of eye, that hot, that late at night in trying to get OR time for something like this. So IV steroids at 1 gram a week and orbital decompression in the left eye was later needed for this patient as well. So pretty aggressive, progressive thyroid eye disease that can be sight-threatening. So some of the things we might be up against. And then later, this is after the eyes calmed down a little bit, after the decompression. We had strabismus from the decompression and also just from the disease itself, lid retraction. So eventually this patient needed strabismus surgery and then upper lid retraction repair. So they needed 3 surgeries, decompression, eventually strabismus, and then eyelid surgery as well. So this is where we started in 2015. This is July of that same month, so 3 months later, how hot and angry those eyes got. You can see that lid retraction right here in that right eye, especially the vertical deviation. And then we've calmed down, so maybe we're not as active disease. We still see a lot of lid retraction, diplopia. 2016 and then 2017, we finally got to more of a normal disease state where we've done decompression, we've done strabismus, we've done eyelids. And so it's really quite a journey these patients have to go through, right? Over 2 years. Before we get them back to normal. So that's 2 years of diplopia, 2 years of eyelid retraction and exposure. I just want you all to appreciate how it took 2 years and 3 surgeons to get this back to normal. And I'll use that term loosely here. Because one thing's got to be calmed down before they do the next thing, and then that's got to be calmed down before they do the next thing. So these surgeons, it's quite an ordeal for both surgeon and patient. Again, if we think about which extraocular muscles are affected, the old mnemonic is I'm slow. So which EOMs are affected first? This is the old board question. I'm slow. Inferior rectus tends to be the favorite of thyroid eye disease, then the medial rectus, superior rectus, lateral rectus, then the oblique. Again, this is a fibrotic restriction. So if the inferior rectus is inflamed and fibrotic, the patient will have trouble looking up because that muscle won't relax. That muscle won't let the eye go up. The other board question was, or trick about thyroid eye disease is, pushing in to see if there's resistance on retropropulsion. But also checking eye pressure and up gaze. So if your pressure was normal or 18 in primary gaze, if you looked up and got that restrictive compression, your pressure would be higher in up gaze. So if you did tonal pen in primary gaze and got 18, patient looks up and it's 25, you'd be worried about some constrictive compression of the eye, inducing that hypertensive state. All right, there's different ways of grading thyroid eye disease. This is some of the things you might think about. It's kind of the typical 0 to 4 grades that we do: absent, mild, severe. Proptosis, we talk about around 3 millimeters. Same thing as IOP again, if it's greater than or equal to 3 millimeters, that's kind of weird. So if there's asymmetry of 3 millimeters, if there's increase of 3 millimeters, we get to another stage of severity. And lid retraction, we can measure that light reflex to their upper lid and seeing lid retraction greater than or equal to 2. Again, getting back to the whole story here, the whole patient. Thyroid eye disease is the most common extrathyroidal manifestation of Graves' disease, that these two things are associated. But again, I want you to think of them as separate entities. So up to 50% of patients with Graves' disease will develop thyroid eye disease. So 50% of your Graves' disease patients will develop thyroid eye disease sometime in their life. But it's not required. 10% of these patients will either be hypothyroid, not hyperthyroid, but hypothyroid, or euthyroid at their thyroid eye disease diagnosis. So they don't have to have something wrong with their T3, T4, TSH. And the thyroid eye disease might be present before, during, or after Graves' disease. So it's not always thyroid issues, then eye issues. It could be eye issues first as a sign of autoimmune disease in the entire body. So again, just some things to think about, that not everyone's going to follow this sort of standard change and standard protocol. Again, treatment of the thyroid gland does not improve thyroid eye disease. And it does not mean if they have thyroid eye findings, it does not mean that they have high serum thyroid concentrations. It does not mean that their T3, T4, or TSH is elevated. And Graves' disease, really what our endocrinologist colleagues are worried about is keeping the thyroid levels in check, keeping those levels in check in their body, in their system. They don't really care about what's going on in the rest of their body so much. I mean, they do, but that's not their job, right? Their job is just to keep that euthyroid kind of level so the patient's not hot as a mad as a hatter and dry as a bone and all those sort of things that we talk about. All right, treatment of thyroid eye disease. So thyroid eye disease has kind of been this long disease of watching and waiting. We'll watch and wait until things calm down. We'll do decompression at that point. Then we'll do strabismus. Then we'll do your lids. And the traditional treatments like IV steroids and other things didn't work great, haven't really worked great for patients. Some patients did okay. Obviously, if you have that really red hot eye, steroids, decrease inflammation. But surgical interventions were really reserved for most severe things. They would wait until kind of Rundle's curve has burned itself out. And so Rundle's curve, Rundle was this long time ago. Rundle came up with this kind of theory about thyroid eye disease being this two-phase sort of disease where this is active, inflammatory, progressive stage that eventually burned itself out. And then you're left over with this fibrotic phase where things kind of burned out, and now we're at this stable fibrotic phase. That active phase lasts about 1 year in non-smokers, about 2 to 3 years in smokers. That was Rundle's curve. You heard anyone talk about where the patient is in Rundle's curve. So if we're thinking about how you'd want to treat these patients and looking at Rundle's curve as the disease progression, you'd always want to catch them early and treat them early to avoid getting into that higher level of fibrosis, right? You want to avoid the inflammation, nip the disease state as soon as possible. Just like glaucoma again, would you rather treat a 0.2 optic nerve or would you rather treat a 0.9 optic nerve? You wouldn't want it to get to that level of severity. You want to nip it early. And so that's that ideal time. So physicians generally have talked about thyroid eye disease as this disease state that burns itself out. It's self-limiting. I think if you looked at those cases, I don't think any of those patients would consider that condition self-limiting. So only 2% of patients consider themselves recovered at the end of that fibrotic phase of Rundle's curve. My point here being we have to remember that there's a person on the other side of the slit lamp, And we have to see it from their side too, that these patients are going to be affected deeply by this condition, diplopia affecting their ability to drive, a change in appearance. I mean, you can see how patients get upset about having to wear bifocals. You think that's upsetting to their appearance. Just think about how debilitating this can be to their ego, to their self-esteem, when their eyelids are changing so much. So take care of the whole patient. Make sure the patient's getting the help they need to deal with this condition when you're seeing those patients. Remember to see it from the other side of the slit lamp. All right, so labs. So many of you said, like, yep, I'm going to order some labs for eye care. So as eye doctors, what labs should we order looking for thyroid eye disease? Should we order TSH, T3, and T4? Well, I think if you were listening to me, you'd say no. Those are our endocrinology colleagues' panels. They want to know how the thyroid levels are systemically. What we want to know about is the thyroid stimulating immunoglobulins, TSI. So as an eye doctor, we should really be asking our thyroid or endocrinology colleagues, did you order TSI? Because I'm kind of interested in if this patient has thyroid stimulating immunoglobulins floating around in their bloodstream. So you can order TSI, or there's actually TRAB assays, which will also measure how much thyroid stimulating immunoglobulins are floating around in their body. And it's those immunoglobulins that are going to attach to those fibroblasts and increase that orbitopathy. So TSH, 3T4, they're thyroid activity, and they don't have any little to any relevance with regards to thyroid eye disease. Again, it's an IgG antibody, mimics thyroid stimulating hormone. So it mimics that, which is why you get the thyroid increased hyperthyroidism, but it reacts with the fibroblasts in our orbit, which is what causes thyroid eye disease, those autoantibodies. So previous treatments didn't work that great. There's a lot of years, things like smoking cessation, selenium, vitamin D supplementation, thyroid disease control might be helpful for some patients, but not always our best options. Again, quality of life of these patients need to be acknowledged, and psychologically a common thing that we're under-treating patients like this. All right, one more question here. Teprotumumab just rolls off the tongue on a Wednesday night. Teprotumumab, who's heard of it? Never heard of it. Saw something in passing. Well, good. Kind of everywhere here. That's kind of cool. Awesome. So Tepezza. All right. So Tepezza's kind of brought this into a new normal, if you will, for therapy. So researchers found that the activation of insulin-like growth factor, insulin growth factor 1R, was overexpressed in patients with Graves' disease and thyroid eye disease, which led to the discussion around, was there's an opportunity for treatment? And by blocking IGF-1R, could we inhibit the inflammation and inhibit the fibroblasts being overactivated in orbitopathy or thyroid eye disease? And that's where Teprotumumab came in. So we're seeing activation of these orbital fibroblasts by immunoglobulins. If we block that, can we nip the thyroid eye disease early and often? So that's what they found. I'll just jump through this a little bit. I think I hammered on this, is you're getting the autoantibodies activating the fibroblasts, enlarging the muscles, and causing tissue and fat to hyperproliferate. So this is Teprotumumab's publication for the treatment of active thyroid eye disease. It's in this journal called the New England Journal of Medicine. I don't know if you've heard of it. It's one of those trade journals, that you hear about once in a while. But no, the New England Journal of Medicine, obviously a very accomplished journal, a very respected journal. Teprotumumab. So this is open access if you would like to read this. This is where Teprotumumab came in. And was FDA approved for thyroid eye disease in January of 2020. A phase 3 trial found Tepro caused at least a 2 millimeter reduction in proptosis, could significantly reduce both proptosis and diplopia in patients with active, moderate to severe thyroid eye disease. And at 24 weeks, which is kind of the end of the treatment phase, 83% of patients versus 10% of controls experienced a reduction in proptosis. And every secondary outcome also had significant improvements with teprotumumab versus placebo. And that was clinical activity score, diplopia, quality of life score. So this is from the publication. You can see baseline versus week 24. And if you can't notice the details, read the article and things like that. But I think it's kind of like, wow, right? All right, so a primary endpoint being proptosis, reduction of proptosis. This is their active versus placebo in their controlled trials. Proptosis, clinical activity score, and patients with a clinical activity score of 0 or 1. We'll call it clinical activity score eliminated groups. And you can see the statistical significance here at week 24. All right, so I hope that proved to you that that medication works pretty well for patients with thyroid eye disease. Again, it was active, moderate to severe patients. Side effects. What side effects should we know about teprotumumab? Because every medication has some. What do we need to know about? What do we need to avoid? What do we need to educate our patients about? So of special interest, hyperglycemia was seen in a couple patients. This may also worsen inflammatory bowel disease and hearing impairment in 5 patients. So some hearing changes occurred in some of the patients in these clinical trials. So those were the 3 big things. There were some other things seen, but the hearing impairment was kind of a weird thing that they weren't expecting to see in these clinical trials. And that's kind of evolved as this, like, again, this is 2020 that things were FDA approved. But the new updated label for teprotumumab is here. It may cause severe hearing impairment. In some patients, it may be permanent. So patients' hearing before, during, and after must be screened, monitored, documented, and educated regarding these risks. So those patients are going to need some blood sugar measurements before. If they have any sort of intestinal thing, we have to talk to the gastroenterologist. And then we have to do some audiology screenings before, during, and after. So there's a lot of actually research going on with what goes on in the ears with thyroid dysfunction and also with treatment of teprotumumab. And so there's some thought, like, do these patients have some dysfunction already? Is this part of thyroid, autoimmune thyroid disease? So we're really going to learn a lot more about that, I think, in the years to come, but something everyone needs to be aware about and be a team so we can get these patients educated. The biggest thing here, this new drug kind of shatters that watch and wait mentality, right? We wait until they're stable and then do decompression and strabismus. If we can nip this earlier, if we can catch that earlier in Rundle's curve, we have to be better practititioners. Because now we have a drug that could catch this early, treat it early, avoid emergent orbital decompressions, hopefully, and save patients' vision and lives too. I think with how debilitating this condition can be. So we, as primary eye care providers, need to be more aggressive with treating this, looking for it, because it's not a watch and wait. It's not a, well, I guess it was thyroid eye disease anymore. It's, hey, I got to catch this thyroid eye disease early because there's an opportunity to treat these patients better than we ever could before. But also there's a growing body of evidence that this also treats chronic thyroid eye disease. So there's a bunch of data. It's actually approved now for chronic thyroid eye disease as well as active. There's some publications around this if you want to dig into those deeper. But also, we saw a big improvement in patients with chronic thyroid eye disease. This is a patient with a 9-year history of thyroid eye disease before and after teprotumumab treatment. And so you can see the improvement in exophthalmometry, lid retraction, diplopia scores going down, similarly to active patients. So when we think about this being this kind of stagnant, fibrotic, stable phase, maybe we're wrong. Maybe there's still some sort of active stimulation of these fibroblasts to keep things sick, if you will. And if we can deactivate that signal, can we help these patients with chronic thyroid eye disease as well? I think so. So looking at this data and looking at that, dealing with that for 10 years. So what sort of symptoms when patients come in, if we're going to be better doctors and catch this early, we're all going to be more aggressive and screen our patients more aggressively and really be detectives, what sort of things should we look for in our patients? I think double vision's going off. That's good. Love it. Good. I'm going to move forward just for the sake of time. But all of those answers are correct. I think diplopia, like, hey, if there's diplopia, we got to think about why. But I also want you to think about patients that are presenting with ocular surface disease symptoms. So orbital congestion, allergic conjunctivitis. So a lot of these patients have itching symptoms. So if you're seeing like, yeah, this smells like allergic conjunctivitis, no papillary reaction, doesn't respond to treatment or allergy drops, maybe it's not ocular surface disease. So any changes that we see, again, in vision, remember to check that optic nerve too. Let's skip along that one. This is a recent case that I just saw over the last couple weeks. This is a patient, 6-year-old female, type 1 diabetic for many years, taking levothyroxine for a couple years, presented to a doctor, it wasn't me, in June, complaining of a red left eye, and diagnosed with dry eye, treated with steroids, tears, lid hygiene. Patient came back, was no better, but the exam findings said the left eye wasn't as red. Steroids tend to reduce redness. But the patient was saying, no, I'm no better, I'm no better. Well, plugs were inserted, and then the patient was sent to me for a dry eye consultation. So I talked to the patient a little bit more. They said, yeah, my eyes really started getting worse this spring, 6 months ago. I've had dryness for a long time, but something changed. Something's going on. What does it feel like? Well, they water, they itch, they burn, kind of all the same things. Itch, I don't see as much in my dry clinic unless there is something allergic going on, but sometimes you do along the lids with things like Demodex, etc. Inferior SPK, MGD. This is a patient's, this is a tear film stability evaluation. It's kind of like a non-invasive tear breakup time. And so when you look at this, you can say, oh yeah, that left eye has more tear breakup time, right? Those little areas of tear breakup. Is there anything else you see? Is there anything else that makes you think like something's asymmetric here? Here's another fluorescein staining picture from our dry eye workup. We can see like that right eyelid looks a little different than that left eyelid. We have to see the patient as a whole. So something's different there. When I saw the patient, I said, tell me about your eyelids. It looks like they're a little different in these pictures here. She's like, yeah, I know my right eyelid, I think it's really getting a lot droopier since the spring, that my right eye is getting droopier and droopier. My complaints are all in my left eye, but my right eye is getting droopier. Do you have an eyelid specialist that could fix that for me in your group? I said, oh, really? Let me check your Hertels. And so lo and behold, there's some asymmetry and maybe a little elevation in this patient makes me a little more suspicious here, right? So what do you do next? Quizzing you all. If there was a poll here, you'd put down your answer. Well, I ordered a TSI. So I said, tell me about your thyroid dysfunction. Yeah, I don't know. They just put me on Synthroid. Do you have anyone mention Graves or Hashimoto's or anything? No, they never mentioned anything like that. Did you have radioactive iodine therapy? No, I never had anything like that. Let me just order this. I know you just had a thyroid panel a couple months ago. I don't have those results because we're not part of your system. Let me just order this. I'm sure your thyroid specialist didn't order this. And so we ordered thyroid TSI, and lo and behold, it's elevated. It's supposed to be below 1.3, and it's 3.8. Suspicions rising. What do you do next? Giving you a minute to say your answer. We ordered a CT. I said, why is that proptotic? Why is there an asymmetry in Hertel? Is it just normal skeletal variation, or is there something going on? So non-specific enlargement of the left inferior rectus was the report. I couldn't get I haven't gotten the CT yet. I've requested it, the CD drive of the CT yet. It's on its way. Like I said, I just saw this patient. So some enlargement of the inferior rectus. Remember which one is most affected in thyroid eye disease? Time is slow, right? So inferior. But now what? What do we do with this patient? Well, I think luckily this patient's pretty mild, pretty subtle, right? But I think we want to catch that, intervene, and maybe talk to this patient about, really finding out if this is thyroid eye disease and treating that, or talking to the patient about treatment options for that. So because this is mild and subtle and I needed some help, I did have that patient co-managing this patient with the oculoplastic specialist. Again, chemosis with injection overlying the extraocular muscles, something to think about with regards to, is it just dryness and exposure, or is that actually some active inflammation deeper overlying the extraocular muscles? These patients tend to have more chronic ache and pain as opposed to the more common shooting sharp pains that are associated with dry eye and corneal disorders. Again, and this is some interesting data. This is symptoms at the thyroid eye disease diagnosis and during chronic thyroid eye disease. And so you can obviously see dryness, grittiness, pain, headaches, light sensitivity, but itching is really high in both chronic and acute. So all those things are there and things you should be aware of when you're hearing those symptoms. These were patients with diagnosed thyroid eye disease, and this is what they were complaining of. Quality of life is impacted by these patients. I think I got up on the soapbox enough about that, but quality of life is an important thing. Dry eye and thyroid eye disease. So the dry eye prevalence in patients with thyroid eye disease is there. It's not just their thyroid eye disease. The thyroid eye disease might be worsening their ocular surface disease, but these patients have dry eye, and who can better treat their dry eye than an optometrist? The huge risk factor of her comorbid condition. And we'll actually see lacrimal gland volume and tear production improve after the treatment with Teprotumumab. So Teprotumumab might be helpful for these patients with really severe ocular surface disease. So that was an interesting study and an article showing that the lacrimal gland rebounded, improved, and increased tear production. That's that data. We'll also see other changes. So it's a condition of the eye, but also the face, that there seems to be this extracellular matrix fat reconstruction that just occurs in the whole face, not just the orbit. So something to think about from a dermatologic perspective and as we look at these patients as a whole. So again, these patients have quite a journey ahead of them when they're diagnosed with thyroid eye disease. Seeing a primary care doctor, endocrinologists, eye care providers, and surgeons, neuro-ophthalmologists. So it really does take a team to properly manage these patients, and optometry needs to be at the heart of that team because we're so good at treating the ocular surface disease. We're so good at treating diplopia. We're so good at listening to our patients. We're so good at following our patients closely and not letting them slip through the cracks. So we need to be at the heart of this team, and we need to be integrated in that team of subspecialists, whether it be neuro-ophthalmologists, oculoplastic specialists, endocrinologists, primary care doctors. So build your team, network with your team, make relationships with your team so you can better serve your patients, because you will be seeing these patients with thyroid eye disease. And then it is an infusion, up to 8 infusions separated by 3 weeks, usually 24-week cycle of that infusion for Teprotumumab. And I'll wrap up there, I think, here.